خير عندكم. طيب, this is going to be a very long session, فهنمشي فيه سريعة ونختصر فيه كثير, and this is a big topic. طيب. Okay, so as usual, this presentation and all presentation will be taken from UpToDate and the NCCN. Okay, this is just a cartoon of the lymph node, just showing that is as any quote unquote an organ has artery, vein, and this is just a cross section of a lymph node showing the different parts of the lymph node. Our interest is mainly the germinal center and the follicle, but all other parts will be an origin of some kind of a lymphoid malignancy. Malignancy from the lymph node or the lymphatic system originates from either B cells progenitors or T cell progenitors or mature B cells, T cell or natural killer cells. The presentation of non-Hodgkin lymphoma is very heterogeneous, but the general presentation could be a B symptom, which is either a fever, night sweats, or weight loss, or sometimes just fatigue. Also, the presentation varies according to the histologic subtypes, like Burkitt lymphoma. The presentation is typically acute. Diffuse large B-cell lymphoma, the presentation is subacute, and follicular lymphoma, typically the presentation is chronic. Also, the presentation of lymphoma varies according to the site. It could be just a large lymph node, a lump in the neck, under the arm, in the groin. So the patient may present with just a lump. Or if the lymphoma involved the GI, the presentation would be GI symptoms, nausea, vomiting, bowel changes. Or if it is cutaneous lymphoma, it would be like a skin rash. CNS lymphoma may present like a stroke. So it really depends on the site of the disease. Also, the lymphoma may present as an emergency in case of tumor lysis syndrome, like Burkitt lymphoma, hypercalcemia. Could be obstructive presentation if a lymph node press on the superior vena cava, present with superior vena cava syndrome. Hyperviscosity in case of Waldenstrom, spinal cord compression if it involved the spines. It could be meningitis, or it could be hematologic presentation, like acute, like autoimmune hemolytic anemia or ITP. Lab CBC may show pancytopenia in case of bone marrow involvement or hypersplenism or autoimmune hemolytic anemia, or it could be a lymphocytosis in case of leukemic phase of the lymphoma. In the lab, LDH is a very important test to do. It could be a high LDH. It's used for the IPI, the International Prognostic Index. Hyperuricemia in case of TLS, tumor lysis syndrome, hypercalcemia, M spike, monoclonal spikes. So diagnosis, you need to remember for the diagnosis, typically we like excisional or incisional biopsy, and that will help for the diagnosis. It will give us the structure of the lymph node, and that's it for the classification too. Core needle biopsy sometimes is acceptable. If we send tissue, remember the tissue should not be fixed, should not be sent in formalin, should be sent in the RPMI media, not on formalin, and should not be fixed tissue. So for the from the tissue, we can tell if it is follicular, diffuse, and also we can tell about the grade. So histology, flow cytometry is the key to make diagnosis of different lymphomas or T cell, B cell. These are the markers. If you can see that the T cells usually the lower number, the CD, which is the cluster of differentiation, usually the lower number, CD3, CD4, CD7. The B cells usually the higher number, CD19, 20, 25, CD79. Just an observation. A molecular testing is very important for the B cell receptor and T cell receptor rearrangements. And of course, the karyotypes, the chromosomal analysis, and the FISH is very crucial for diagnosis and subclassification of lymphomas. Just we need to remember, no FNA. If you suspect lymphoma, never do an FNA. It is not used to diagnose lymphoma. It may be used to diagnose carcinoma, but not lymphoma. Lymphoma, the best, again, excisional or incisional biopsy or a core needle biopsy is acceptable, but never do an FNA to diagnose lymphoma. Initial evaluation, we do a CBC, peripheral blood smear, to look for circulating lymphoma cells like leukemic phase. Of course, we need kidney function, liver function. LDH is very important, uric acid, SPEB, and immunoglobulin levels, especially for Waldenstrom, the IgM. The beta-2 microglobulin is a kind of a marker. HIV testing is very important. Hepatitis B and C serology. Bone marrow test is not typically done, especially if a PET scan is done, which shows, if it shows a bone disease, we don't need a bone marrow, but otherwise you may need a bone marrow in case of pancytopenia or cytopenia, any of the cytopenia. Lumbar puncture in certain cases, especially if there is neuro findings, abnormal brain or MRI, if there is more than one extranodal site, external sites such as testicle, breast, kidney, adrenal gland. So you do an LP, CT scan, of course, CT PET, and echocardiogram because you'll be using cardiotoxic drugs and anthracyclines. Staging, you're all familiar with the staging system, Logano classification. Simple stage one region of a lymph node or extranodal. Stage two regions of lymph nodes in the same side of the diaphragm. 3 above or below the diaphragm. Stage 4, disseminated disease. And bulky is also needed for the staging. Basically, for bulky disease, there is different definition of bulky disease. For follicular, we use 6 centimeter or more. We call it bulky. For diffuse large B-cell lymphoma, there is a range of 6 to 10. You may see 7.5, but most people rely on 10 centimeter lymph node mass to call it a bulky disease, and we define that by the letter X. Also, we use A for no B symptoms, B for B symptoms. So I'm going to divide the lymphomas into mainly two categories: B cell and T cell. So we're going to start with the B cell. Remember, B cell is the tumor, the cancer marker, which is characterized with this CD or cluster of differentiation. As I said, just the higher number, CD19, 20, 25, 79. The higher numbers is characteristic for the B cell, except for the follicular lymphoma. We see the CD5, which is the T cell marker, but it's positive for that kind of lymphoma. Intermediate and high-grade lymphoma, if you remember, the all classification usually is defined as low grade, intermediate grade, and high grade. So this is intermediate grade and high-grade lymphoma together. The most important in this category is diffuse large B-cell lymphoma, DLBCL. So I'm going to start with the case. So it may keep us on track when we go through the slides. So this is a case. This is not a real case. So this is a 62-year-old male patient, healthy, not on any prescription drugs, presented with abdominal pain. He reported having fever and weight loss for 3 months. He continues to work full-time as a teacher, just telling us his performance status is good, ECOG of 0 or 1. On exam, found that he had abdominal tenderness in the epigastric fullness and enlarged left supraclavicular lymph node. So the biopsy of the supraclav lymph node showed germinal center B cell, diffuse large B cell lymphoma. You have done a PET scan, and the PET scan showed a 5 centimeter mesenteric mass, SUV 17, bilateral axillary nodes, active, left supraclavicular lymph node, 3 centimeter in size, SUV of 15. So you can tell this is at least stage 3B, non-bulky. So lab, remarkable for hemoglobin of 15.5. Otherwise, with the normal range, you have done an echocardiogram and it showed LVEF of 55%. So now I think you have done everything. Now he is in your clinic for a follow-up visit to discuss treatment options and plan of care. You determine that he has a stage 3B, as we said, non-bulky diffuse large B-cell lymphoma, NOS, not otherwise specified. So, question: name 3 things that you need to know or to order before making your final treatment. You don't have to answer. You could answer to yourself just to check yourself on the answer. But if you want to open the mic and answer, that's fine. If you want to send a chat, fine too. So, diffuse large B-cell lymphoma is the most common subtype of non-Hodgkin lymphoma. 25% of all the lymphomas are diffuse large B-cell lymphomas. These are the markers, as we said, the cell of origin. So there are 2 cell of origin for the diffuse large B-cell lymphoma. Just focus into that. So remember that lymph node diagram. So in the germinal cell, lymphoma may arise from the germinal cell and what we call germinal center B cell, GCB, diffuse large B-cell lymphoma. This is more common, relatively good prognosis with R-CHOP, so classic treatment. Then there's another type, which is the non-germinal center B cell, or also we call it activated B cell, ABC, diffuse large B-cell lymphoma. This isn't, fortunately, not the commonest. It has a high relapse rates, less favorable prognosis with R-CHOP. So the treatment for this is still not really. There is no consensus on the best treatment for this. For all diffuse large B-cell lymphoma, remember to need to check for c-MYC, BCL2 and BCL6 gene rearrangement. Why? Because lymphoma with c-MYC, BCL2 or BCL6 by AHC, that we call it double expressor. So still may not be bad, but you need, if you find double expressor, that means by immunohistochemistry, c-MYC, BCL2, BCL6 positive, don't stop there. Then you need to do the FISH. So you check for both by FISH, for the 3 rearrangement by FISH. So if you find a c-MYC plus BCL2, that's what we call double hit. If you find, in addition to that, a BCL6, that's another addition. But mainly the c-MYC and BCL2. Those, when we say double hit, we mean those. If BCL6 is positive, it just make it even worse. But double hit, by definition, means c-MYC, BCL2 positive with or without BCL6. Why we need to know that? Because this subtype of the diffuse large B-cell lymphoma has a high relapse rate, poor survival rate with R-CHOP. So the treatment for this is different, because usually when we talk about lymphoma, the standard for many years is R-CHOP, but it is not for this subtype. So this is just the WHO classification. So let's just go to the treatment. Before we talk about treatment, we usually try to stratify those patients based on the risk of recurrence and response to treatment. So every patient with diffuse large B-cell lymphoma, we should calculate the IPI, International Prognostic Index. We use age, more than 60, that's we give it a 1. LDH, more than normal range, we give it a 1. ECOG, the performance status, more than 2 or more, we give it a 1. Stage 3 or 4, we give it a 1. And any extranodal more than 1, we give it a 1. And then we come up with the score. So this score actually gives us some idea about the CR, or the remission with the R-CHOP. For example, patient with 1 or 0 or 1 risk factor on the left side, the CR is 87%. 2 risk factors, 67% CR. Intermediate risk, which is the 3 score, 55, and so on. So high risk, 45%. So the IPI is very important for the when you treat patients and talk to the patient about prognosis and the outcome. There is a revised IPI, but this is enough. You can go by IPI if you want to read the revised one, and there is also age-adjusted IPI. But just to simplify it, this is enough. And actually, to simplify this more, they develop what is called a stage-modified IPI, SMIPI. Basically, just try to make it simple for the stage 1 and the stage 2 lymphomas. For this, we use the age of more than 60, we give it a 1, LDH more than normal, or more than normal. Performance status is ECOG of 1 to 2, is stage 2 or 3. And you know what is the ECOG score, but briefly means the ECOG of 0, patient is totally asymptomatic. The ECOG of 1, some symptoms. ECOG of 2, has symptoms, but more than 50% up and around, could do things. ECOG of 3, less than 50% activity, more than 50% is spent in the bed or just confined to home. ECOG of 4 means the patient is bedridden. So stage 2, and this is for stage for the low stage. Also stage, we count it stage 2 or 2E extranodal. That's a give it a 1, and then we divide the score simply just to 2 scores. 0 to 1, low risk. 2 to 4, high risk. Simple. So this is, we use it for stage 1 or 2 only, and this is going to be when we talk about treatment, we will mention that IPI, SMIPI. So we go back to our case. So now the question was, name 3 things that you need to know or order before making your final treatment. So after we talk about this, if anyone want to mention something, that should be fine. But here are what you need to know. You need to know the LDH. Remember, we talked about the IPI. So his LDH is more than 1.5 upper normal. So that's another one. That's another one. So that makes his IPI score of 3, correct? Because he has stage 3. He's 52-year-old. So these are this is 3 points. Make it IPI score of 3. So the second thing we need to know, remember we talked about the germinal center cell, and we said we check for the c-MYC. So we check c-MYC, BCL2, BCL6 by FISH, and all came back negative. So that means this is not a double hit. This is just a NOS, diffuse large B-cell lymphoma. So this is not a double hit, which is better prognosis. So it's not a double hit. So that's what you need to know. And then we need to know, of course, the hepatitis B serology. When we talk about hepatitis B serology, we need to know hepatitis B surface antigen and core antibody. Why the antigen? Because the antigen is the surface of the cell, and the core is usually indicate exposure to the hepatitis B virus in the past, because it's part of the virus. So we need to know the B, and the reason is when we expose those patients to anti-CD20, if they have been exposed to the surface antigen positive, they need to be on some kind of treatment. Otherwise, the virus will reactivate itself. So now it's still in the case. So what you recommend for this patient? Now you have all the information. You will be able to give the patient recommendation for treatment. So here are the options. Here are the options. You give the patient these 3 options. Which one you will choose? You choose either resection of the mesenteric mass, followed by chemotherapy R-CHOP for 3 cycles, followed by RT. This is one option. Second option, R-CHOP. Third option, a new drug called POLA plus R-CHOP. Fourth option, regimen called RIC, rituximab with an ICE, followed by autologous stem cell transplant. So these are the 4 options, and we need to choose one of them. one or two, or whatever you recommend. So let's just talk about treatment options in general. In general, first-line treatment for diffuse large B-cell lymphoma, we divide them to early stage and late stage. Early stage is stage 1 and 2. Later is stage 3 and 4. So for stage 1, we use the stage-modified IPI. If it is 0, remember we call this low risk, non-bulky disease. For those patients, we give them R-CHOP for 3 cycles, and we do PET. If the PET is negative, then we give 1 more cycle. If the PET is positive, that means partial response, do a biopsy. Don't stop there. And then if the and then you may give 1 or 3 cycles, with or without ISRT radiation to the involved area, or you can give radiation only. But if the biopsy, if the PET scan showed disease progression, of course you need a biopsy, and you call that relapsed refractory disease, and that's a totally different scenario if the patient has a refractory disease. On the other hand, for stage 1 or 2 with the stage IPI from 1 to 2, but bulky and no extensive mesenteric disease, those patients, you give them 3 to 4 cycles of R-CHOP and do your PET scan. If negative, you give 2 to 3. Basically, try to make it total of 6 cycles with or without radiation to the bulky area. Of course, this is partial response. Still, you give the same R-CHOP to make a total of 6. But progressive, you call it refractory, and that's the total different area of treatment. For the stage 1 or 2 with the score of more than one, or has a bulky disease plus a score of more than 1, or has a extensive mesenteric disease. So remember, mesenteric disease by itself is a risk factor if there is extensive mesenteric disease. In those cases, those stage 1 or 2, if they have a big mesenteric mass with the score of more than 1, we basically treat them exactly like a stage 3 or 4, which we're going to mention down here. So for those, we give them R-CHOP or RCHP. Basically, we give for 2 to 4 cycles and follow the PET. Actually, this should be a POLA RCHP. There's missing here POLA, which is the new drug, or adjusted APOC. If negative, and you do your PET scan if negative, or partial response, you complete for a total of 6 cycles. Of no response or progression, of course, you biopsy, and that's a refractory disease. We'll talk about the refractory disease. Refractory disease means disease progression immediately after treatment. So there is no time different from a response and recurrence. This is a refractory. This is just a reminder of R-CHOP, rituximab, cyclophosphamide, hydroxydonorepacin, oncovine, or vincristine, and prednisone. These are the other first-line drugs, because we said R-CHOP is the drug of choice, but for patients with poor left ventricular EF, these are the regimen right here on the left, on the right side. These are the regimen that you use for frail patients, patients with comorbidities, elderly, age of more than 80. These are the regimen. The commonly used is R-mini-CHOP, 50% dose reduction CHOP, plus rituximab. Okay, that's the POLA, what I'm talking about. There is a recent clinical trial which brought to us a new drug and a new regimen, almost replacing R-CHOP. It is the phase 3 clinical trial, POLARIX trial. In this trial, what they chose patients with previously untreated diffuse large B-cell lymphoma or high-grade B-cell lymphoma. They exclude transformed lymphoma, primary mediastinal lymphoma, and patients more than 80-year-old. So this is the design of the study. And of course, they use patients at high risk with an IPI of 2 or more. So patients with high risk. And they divide them into 2 arms. One arm, they give this drug POLA, which is a Polavi, which is a polatuzumab. It is an anti-CD79. They give it with the RCHP, which is rituximab, cyclophosphamide, doxorubicin, and prednisone. So basically, they remove oncovine or vincristine and they give the pola instead of it. So and they follow that with 2 cycles of single agent rituximab as maintenance, versus the standard of care, which is the R-CHOP. They give 2 rituximab at the maintenance also. So basically, very well controlled 2 arms to test adding this drug or replacing the vincristine by this pola or pola-V. So the results show that the experimental arm, which is the pola plus RCHP, basically CHOP without vincristine, they found that 27%, this new regimen demonstrated 27% reduction, reduced risk of progression, risk of relapse, or even risk of death. It improved progression-free survival significant, and that's significant with the hazard ratio of 0.73, 76 versus 70. So it become one of the standard of care right now. There is no clear benefit in germinal center B cell. You remember the ABC or the germinal cell subtype. So there is no clear benefit in the B cell-like subtype and bulky disease. Of course, this study is new, so we need a longer follow-up to confirm durable complete remission. So we need more time but it's still a standard of care. But if you use R-CHOP, it's not wrong, but this is preferable. This is just a little bit about the drug, Apology or olatuzumab. This is the indication for it. So now it is considered a standard of care first-line therapy in combination with RCHP, basically R-CHOP without vincristine, or the oncovine. It is indicated at the first line for stage 1 or 2 without extensive mesenteric disease, diffuse large B-cell lymphoma, with the stage modified IPI of more than 1. Or a first line stage 2 diffuse large B-cell lymphoma or high-grade lymphoma with extensive mesenteric disease with an IPI of more than 2. Or first line stage 3 or 4 diffuse large B-cell lymphoma or high-grade lymphoma with an IPI of 2 or more. So this is now the use of this drug. It is also could be given in combination with BR, bendamustine and rituximab for relapse refractory diffuse large B-cell lymphoma after prior therapies. Just you need to know some of the adverse effects of this drug and future reactions. So when you're given, we keep the patient in the office for just to monitor for possible and future reaction, and that could happen even late, 24 hours later. So be aware of that. Peripheral neuropathy is an issue. Opportunistic infection is one of the issues with this drug. So all patients should be given prophylaxis for PGP or PCP and for viral infection. So you use Bactrim for the PCP or PJB prophylaxis, and acyclovir for viral infection. So still, we're back to our case. So what is your recommendation? What you recommend for the patient? So we need to answer that question. So here is the answer for that question. So resection of mesenteric mass followed by R-CHOP times 3, followed by radiation is the wrong answer because we do not do surgery for diffuse large B-cell lymphoma. We don't like to use never in medicine, but no surgery for diffuse large B-cell lymphoma. For lymphoma, later we can talk about surgery for low-grade lymphoma. For diffuse large B-cell lymphoma, this is systemic disease, so surgery is out of question. So that's a wrong choice. R-CHOP is okay. Pola RCHP is the new regimen. Now is head-to-head with the R-CHOP, even is preferred for patients with IPI of 2 or more. Giving rice followed by autologous stem cell transplant is a wrong answer because this is a later or second line for relapsed disease, not front line. So Treatment of relapse or refractory diffuse large B-cell lymphoma. Whenever there is a refractory disease, disease not respond to the first-line R-CHOP or the polar R-CHP, we have to confirm that's a true relapse, even if it is positive. So we do a biopsy. We do a biopsy to confirm the relapse. We do it to rule out other causes for the activity in the PET scan and evaluate for possible change in lymphoma subtype and acquisition of new mutations. So if a relapse happens in less than 12 months, and that's what we call refractory. Refractory means early on. So if relapse in less than a year or a refractory, that's immediately, then the treatment of choice are the following. So this we use CAR T therapy, and these are the two CAR T that now available and being approved to be used in case of refractory or relapse disease in less than 12 months. And of course, for the CAR T, we'll talk about a little bit about CAR T, but here are the bridge therapy. So to give CAR T, you prepare or give a regimen, chemotherapy before CAR T, and these are the regimen that could be used as a bridging options for the CAR T therapy. CAR T, what is CAR T? It is chimeric antigen receptor T cells. Basically, it is genetically modified with gene that encodes the CAR to direct the patient T cell against the lymphoma cell. Basically, it's almost like manufacturing a cell. Of course, not make it from scratch, but basically just build a new cell, which we call it a CAR, that carry an antibody to destroy the lymphoma cells. That's a CAR. That's a CAR T. And here are the CAR T therapies that is now available. Just be aware of the neurological toxicity, which is and the cytokine release syndromes, which present as high fever, flu-like symptoms, hypertension, mental status changes, and we treat with steroids and antibodies. Another, this is when we have a patient, when there is a relapse or refractory disease, we ask ourselves immediately if the patient is transplant eligible or not, based on the performance status and comorbidities. So if you determine that the patient is bone marrow transplant eligible, so your first, then how you treat. If you determine if the patient is transplant eligible, we give salvage chemoimmunotherapy. So give chemotherapy, and then we follow that with autologous stem cell transplant. And here are those regimens before the stem cell transplant. So we give 2 to 3 cycles and evaluate. If there is a response, we take the patient for the transplant, autologous from the patient's own bone marrow. And these are the regimen right here. Remember we said the non-germinal cell, the activated B cell, the ABC, or the double hit. You remember we said those are the bad ones, double hit. Remember the c-MYC, BCL2, plus or minus BCL6 gene mutation. This is double hit. Those are the bad ones. There is no standard of care for those yet. So there is no consensus what is the best. So that's why those patients we like to treat them in a clinical trial to try to find a better regimen for them. But if you use chemotherapy, you use the R-GDP, gemcitabine, and dexamethasone, and platinum. So we use platinum, either platinum carboplatin or oxaliplatin, GDP. This is just from the Parma study showing that salvage chemotherapy with the high-dose chemotherapy followed by autologous stem cell transplant, the 5-year survival, 46% versus 12%. So overall survival is 53 versus 32%. So the chemoimmunotherapy followed by autologous stem cell transplant has proven that effective. And this is the conditioning regimens. So if you determine that the patient is not transplant ineligible for transplant, so what do you do? So those patients, we take them for the CAR T. And we talk about CAR T a little bit, or you can give them POLA if they don't want to go through CAR T, it's not available. because this is a new treatment, need a special center to do the CAR T. If that's not a choice for the patient, then Pola-V plus or minus B, which is the brentuximab with or without rituximab, is reasonable. Another regimen, which is very effective, by the way. This is a CD19-directed cytolytic antibody, which is we call it Monjuvi. And the regimen is called Tefalin. Tefalin is a combination of the Monjuvi, which is an infusion, plus the lenalidomide, which is the Revlimid. Remember, Revlimid is the new generation of the thalidomide. So this is just a cytotoxic chemotherapy. Another regimen is EPOC. This is just different regimens in case the patient is transplant not eligible. Really, personal preference is Tefalin because it's simple regimen, very effective, and some people see it as equivalent as CAR T, but not really. But it's a good option if CAR T is not available. Tefalin. This is another regimen that it could use. Transplant eligible after second relapse or after autologous. So if the patient relapse after the autologous stem cell transplant, really clinical trial or the CAR T, allogeneic stem bone marrow transplant, and those are the regimen just I mentioned. Which is a CD19-directed antibody, Monjuvi, which is with the Revlimid or lenalidomide, which is the Tefalin regimen, very good in this situation. There's another drug which is another CD19 antibody with the conjugate drug with an alkylating agent. And also, there's a new class of drug, which is now kind of competing with CAR T because it's more simple. It could be given. You don't need the setup for the CAR T. It has to be given in tertiary center, well equipped. So a lot of work for CAR T. So this is kind of another option, which is now is becoming competing, as I said, with the CAR T, which we call it BiTE, which stands for bispecific T cell engineered antibody, BiTE. Another option is, well, as we said, CD79 antibody. You can give it with the bendamustine. Okay, so BiTEs. BiTEs is used for refractory or relapsed diffuse large B-cell lymphoma or large B-cell lymphoma arising from follicular lymphoma after at least 2 lines of systemic therapy. So I think very soon it's going to be moved to the front line, not front line, at least as the second line, but now at the third line. It is a biphasic. We mean by biphasic, bispecific. I mean bispecific antibody. It hits the CD3, which is T cell, and CD2, which is a B cell. So basically, it is the B and T antibody. Those are the 2 BiTEs now available and in use. Colombi, which is one of them, and been in use. At least in the state available. I don't know about other places, but those are the new drugs, and they're effective with the overall response rate of 56% and CR 43%. Remember, those patients are heavily pretreated. This is third line. This is someone that is failed frontline chemotherapy, someone failed even CAR T, someone failed even transplant. So to have an overall response at that level is very high. So what about the maintenance therapy for stage 2, 3, and 5? Maintenance therapy, rituximab and lenalidomide, which is the Revlimid, improve failure-free survival, but it does not improve overall survival, so it is not recommended. So maintenance is rituximab, like what we do for the low-grade lymphoma. We give rituximab every 2 months for 2 years. The maintenance, we don't do that for the diffuse large B-cell lymphoma. So it's not recommended. It does not. So basically, does not outweigh the cost and toxicity. So it is not recommended to give maintenance rituximab for diffuse large B-cell lymphoma. like the way we do it for the low-grade lymphoma. Bulky disease, should we give radiation? Not routinely recommended since the era of rituximab-based therapy, because in the past, before rituximab, when we give CHOP, the standard is to give radiation therapy to the bulky area of disease. It is not standard of care. It is not routine anymore since the use of more effective drugs, including the CD20 antibodies. And of course, I guess it would be not even after it was not after rituximab. So imagine after polo, that's more effective. So it is not routine to radiate the bulky disease area, but case by case. Here is the survival for the stage 3 and 4 without therapy, only months. So it is a deadly disease, diffuse large B-cell lymphoma stage 3 and 4, not treated, patient dies within months, less than 6 months. Chemotherapy or rituximab or CHOP, POLA, or CHP may cure patients with a survival rate 70% at 3 years, 60% at 5 years, and 45% at 10 years. This is the rituximab era. So maybe with POLA even better. What about the non-germinal center B cell or the ABC activated B cell, diffuse large B cell lymphoma? So remember we said there is no standard of care yet. There is treatment, but there is no consensus what is the best. So we still will try to look for what is the best. Remember this type of diffuse large B cell lymphoma had a high relapse rates, less favorable prognosis with R-CHOP. So if it is a stage 3 or 4, the best clinical trial if available. Otherwise, use R-CHOP, but add something to it. Revlimid, lenalidomide, ibrutinib, the TKI inhibitor or Velcade, because R-CHOP by itself give you a 5-year PFS of 54% and 50% is not bad still, but it is not the best. We're looking for something better than that. So remember, for the non-germinal center B cell or ABC, R-CHOP by itself is not enough, R-CHOP plus. Okay, so the high-grade lymphoma with a double hit. Remember the c-MYC BCL and BCL2 and BCL6 rearrangement, you do it by, you remember we said if we do it with, if we find that by IHC immunohistochemistry, we send the specimen for FISH. So FISH to detect the c-MYC, BCL2, with or without BCL6, that's what we call a double hit. It has a high relapse rate, poor survival with R-CHOP treatments, optimal treatment not established as a state clinical trial if available, and these are the regimen that could be used. Now we move to a different type of lymphoma, another type of lymphoma, which is the primary mediastinal large B-cell lymphoma. So this is the not very common, but a specific type of diffuse large B-cell lymphoma for patient. Typically, the disease in patient in the 3rd or 4th decade, the patient it originates from the thymic medullary B cells, characterized by the SVC syndrome, airway obstruction, treatment limited, contained within one RT field. We treat with R-CHOP for 6 cycles, and we give involved field radiation, or we give the deaxylated epoch for 6 to 8 cycles. Advanced stage, we give R-CHOP times 6. We don't radiate unless bulky. Disease, relapse, clinical trial. Burkitt's lymphoma originates from germinal center B cells. It is c-MYC positive. Under the microscope has a very characteristic appearance, which is a starry sky pattern. Spontaneous tumor lysis, because it's very rapid. It doubles in days, if weeks or days. Very short tumor, but doubling time. It has 3 forms. The epidemic, which is African, the jaw or facial bone tumor. Remember, in the Muir's pathology, there was a very characteristic of a kid with a huge jaw mass, sporadic or non-endemic, typically in the abdomen, immunodeficiency associated with AIDS, Burkitt-like lymphoma, c-MYC positive. Treatment for B-cell lymphoma, for the Burkitt lymphoma, frequent multi-agent therapy with adequate CNS prophylaxis, clinical trial, and this other regimen, very intense regimen. CHOP is not adequate for Burkitt lymphoma. We move to primary CNS lymphoma, brain, leptomeninges, eye, spinal cord without systemic disease. That's a definition of it. Should not be anything outside the CNS. This is what we call it, primary CNS lymphoma. Risk factors, immunodeficiency, HIV, those are some of the risk factors. A very characteristic MRI of the brain with the periventricular lesion, periventricular lesions, rather than the brain metastasis, which is more peripheral. This is periventricular lesions. You need to do a testicular exam and ultrasound for primary CNS lymphomas. Treatment, very complicated, but I just try to simplify it. For a younger patient, younger means less than 70, with good kidney function, you treat them with high-dose methotrexate based chemotherapy with or without radiation. For a younger patient, but with poor renal function, we may use cytarabine with temozolomide. With elderly patient, we use a cutoff of 70. High-dose methotrexate is reasonable, with or without temozolomide or procarbazine, with or without radiation. A patient with poor renal function and elderly, high-dose cytarabine, temozolomide, Revlimid, ibrutinib, Alimta, with or without radiation. So now we move to a different class of B-cell lymphoma. Low-grade lymphomas. Low-grade lymphoma led by follicular lymphoma, because it's the most common. The second most common lymphoma, derived from the germinal center B cells. So when we look under the microscope, we see mature lymphocytes, which is centrocytes, small cleaved follicular center cells. If you see them under the microscope, you're not going to forget them. You hear about this grade 1, grade 2, grade 3. It simply means when they look under the microscope, we see centroplast instead of centrocytes, which are large non-cleaved follicular center cells. If we count less than 5, we call it grade 1. If we count 6 to 15%, we call it grade 2. Grade 3, more than 15%. And here the flow cytometry, or the immunophenotype of it, you see the CD5. CD5 is a T cell marker, but we see it in follicular lymphoma. Characterized by the BCL2, which is the off product of translocation on chromosome 14/18. Basically, it causes block apoptosis. So cells multiply because we block apoptosis or programmed cell death. One of the tests now available for this lymphoma disease is NGS, next generation sequencing, to check for EZH2 gene mutation, because there is a drug for that. We see that later on. Indication for treatment. So we do not treat all follicular lymphomas. So it has to be an indication. The slow-growing disease, it used to be called disease of bumps and lumps. Patient had a lump, a male patient find a lump. When they shave, they find a mass, asymptomatic, only a lump found, as I said, during shaving. And so it is not typical. We don't typically treat all follicular lymphomas. Local symptoms, we treat for local symptoms if the tumor compromises normal organ function, block something, airway, kidney. The symptoms: fever, weight loss, sweats, night sweats, that's indication. Symptomatic extranodal disease like pleural effusion, cytopenias, which may indicate bone marrow infiltration, or autoimmune hemolytic anemia, or thrombocytopenia, hyperesplenism. Then we treat those. So those are the indication to treat lymphomas. Increase in disease tempo, if a rapid progression of lymphadenopathy, that's indication for treatment. That may, lymphoma may transform into aggressive type of lymphoma. For follicular lymphoma, we try do our best to select patients for treatment. So the Flippy score has been developed and even revised. You can see that here. You can see that here. So management. Follicular lymphoma, the first step of treatment is observation. Try to just observe, see how things go. If you try to treat, you may use non-chemotherapy regimen, rituximab single agent, anti-CD20, and if progressed or if the disease is more aggressive, you may use immunochemotherapy, BR, bendamustine, rituximab is the standard of care, or you may use R-CHOP. This is just a simple management cascade. Hepatitis C virus infection, and if the patient is asymptomatic, treating hepatitis C with interferon ribavirin may lead to CR. So treating hepatitis C infection may treat indirectly the lymphoma. So check hepatitis C for follicular lymphoma. If positive and the patient is asymptomatic, may just try to target the hepatitis C rather than the lymphoma, and that may lead to CR of the follicular lymphoma. For grade 1 or grade 2 follicular lymphoma and not aggressive, not aggressive grade 3A staging, we do staging, CT, PET scan, bone marrow may be needed. So for stage 1, site contained within RT field, you may offer them radiation, otherwise you may just observe. Not contained in an RT field, symptomatic, rituximab or BR, bendamustine rituximab, asymptomatic, initial observation. What about stage 2, 3, and 4? Asymptomatic, initial observation, symptomatic, here are the options, many options. Bendamustine rituximab with or Gazyva, another new anti-CD20. EVP with rituximab and Gazyva. R-CHOP with rituximab or Gazyva. Lenalidomide or by itself or rituximab. Lenalidomide, with the Gazyva or rituximab, chlorambucil with rituximab, Cytoxan with rituximab. So the many options for those patients. For aggressive grade 3A, especially grade 3B, treat them with R-CHOP similar to diffuse large B-cell lymphoma. We mentioned this early, hepatitis C and asymptomatic, we treat hepatitis C. Maintenance therapy. Here we use the maintenance. Remember, we said there is no role for maintenance therapy for diffuse large B-cell lymphoma, but we do use maintenance therapy for low-grade lymphoma. This is from the primer study, maintenance rituximab. We give maintenance for 2 years. It has proven that it improved disease from progression PFS and an overall survival and improved quality of life. Actually, so let me just take it back. It has a similar 10-year overall survival and quality of life, with or without. It improved only PFS. This is from ASH 2020, American Society of Hematology. They said rituximab maintenance significantly prolonged PFS in patients with R-CHOP versus BR. And they said R maintenance significantly prolonged PFS. So basically, we do use maintenance for patients with follicular lymphoma. Typically, the maintenance is rituximab, but we could use Gazyva for eligible patients. What about relapse or refractory follicular lymphoma? Whenever there is a relapse or refractory, especially rapid progression, we do need to we recommend to do a biopsy to confirm the relapse, of course, and evaluate for possible transformation to aggressive lymphoma. For early relapse, less than a year, and the patient is candidate for stem cell transplant or not, we need to determine if the patient is the candidate for transplant or not. If not, we use novel agents or radiation. But if eligible for transplant, we offer chemoimmunotherapy. And if they achieve remission, we recommend autologous stem cell transplant, or may use CAR T. We're going to offer those. So here, as I said, we need to do a biopsy. And here are the options for refractory disease: biphasic antibody therapy, bispecific. You remember we said anti-CD3 and anti-CD20, so bispecific. So this is BITE. So the two drugs, CAR T is an option. And remember we said we do NGS, next generation sequencing, to check for EZH2D mutation. And if it is, we may offer this drug, but now it is said even in the absence of the mutation, you could use the EZH2 inhibitor. TKI inhibitor, BTK inhibitor, we could use that with the anti-CD20. Allogeneic stem cell transplant only in selected patients. Relapse or refractory. This is a study that is showed that the BITE works. This is NCORE NHL1 study. They use one of the BITE drug, which is the biphasic CD20. Keep saying biphasic, bispecific. Bispecific CD20 directed CD3T and CD20 directed and CD T cell engineer. It has shown overall response rate 82%, with 60% of patients achieving CR, very high response. This is a refractory. Remember, this is the patient that is being exposed to more than 2 regimens, so heavily pre-treated patient. So this is very good result. So it is a standard of care, and it is available. What about transformation of follicular lymphoma into diffuse large B-cell lymphoma? So what makes you suspicious for histologic transformation of follicular lymphoma into diffuse large B-cell lymphoma when you suspect that? If your patient with follicular lymphoma present with rapid progression of lymphadenopathy came to you and say, well, I have this lymph node in 2 weeks, 3 weeks, a month, which is follicular lymphoma, usually a disease that's progressed over years. But if they have rapid progression, you should suspect transformation. Infiltration of uncommon extranodal site. So something that is an unusual extranodal site. B symptoms. Patient was asymptomatic, all of a sudden develop fever, night sweats, weight loss, you suspect transformation. Elevated LDH, you have been checking the LDH has been normal, and now all of a sudden LDH is doubled, so you suspect transformation. PET scan lymph nodes with highest activity. Usually follicular lymphoma had a PET scan with the low SUV. If the SUV was 5, 3, 4, and now SUV is 17, 20, high, you suspect transformation. Hypercalcemia of malignancy may indicate transformation of follicular lymphoma into diffuse large B-cell lymphoma. But remember, follicular lymphoma evolved from low grade to higher grade. For example, it was grade 1, it did not biopsy, it became grade 2 or 3A. That's not considered transformation. So how we treat transformation of transformed follicular lymphoma. There is no standard of care yet, but clinical trial is the best. But if you decide to treat outside clinical trial, the treatment depends on prior treatment and aggressiveness of the disease. So you may use just rituximab, radiation only, chemoimmunotherapy, a regimen that has not been used before, R-CHOP, something like BR if it has not been used. If it resembles diffuse large B-cell lymphoma, use R-CHOP, of course. If it resembles Burkitt lymphoma, or double hit, use R-EBOF. So basically it depends on prior therapy and your clinical judgment. Okay, now we move to a different type of lymphoma, B-cell lymphoma. It's cutaneous follicular lymphoma. If present with solitary lesions, radiation is reasonable. If not candidate for radiation, then surgery or observation. Extensive disease, rituximab, or you may use chemotherapy. Now we move to a different type again. Mantle cell lymphoma, MCL. Mantle cell lymphoma characterized by the cyclin D1 gene, which is an off product of chromosomal translocation 11 14 lead to cyclin D gene, which is characteristic and diagnostic for the mantle cell lymphoma. So if you are in doubt between mantle cell lymphoma and other type of like marginal zone or other type of lymphoma, you do cyclin D1, and that is lead to confirm your diagnosis of mantle cell lymphoma. Classical mantle cell lymphoma, characterized by the SOX11, is useful if the cyclin D1 is negative. This gene mutation, SOX11 mutation, indicates aggressive disease. These are the flow cytometry, CD5 positive, CD23 negative. You remember the follicular CD23 positive, really CD5 negative, CD23 positive. Okay. TP53 sequencing. We do sequencing for the TP53. If it's mutated, indicate poor prognosis if treated with conventional therapy. So you remember that. GIT involvement. So mantle cell lymphoma characterized by involvement of the GI tract. So especially for stage 1 or 2, you need to do endoscopies to rule out higher stage, or if the patient has the GI symptoms, stomach, upper GI or lower GI symptoms, we do EGD and colonoscopy. Mantle cell lymphoma may involve the GI tract. So here is the case. So 49-year-old female patient with history of hypertension, diabetes, presented with an enlarging lump in the left side of her neck. She denied the symptoms. So you have done a PET-CT, showed hypermetabolic 11 centimeter lymph node mass in the left side of her neck and small lymph nodes in both axilla. So what test you may order to guide treatment? So choose the best answer. You need one test, only one test that may influence and help you with your treatment decision. Cyclin D1 gene. Would you do cyclin D1 gene, or would you need to do a bone marrow biopsy, or TP53 gene rearrangement, upper and lower endoscopies to complete the staging? What test you need to do? If you have to choose one test, you may need all of them, but here we need one, the most that help you to decide treatment. So mantle cell lymphoma either could be classical TP53 wild type, no mutation, it has a better prognosis. Classical TP53 mutated indicates poor prognosis. Indolent, typically SOX11 negative, IGHV mutated. It is characterized by an leukemic non-nodal CLL-like with splenomegaly. So that you see circulating cells, no lymphadenopathy. That's an indolent. GI or blood or bone marrow only involvement, low tumor burden, and Ki-67 index is low, less than 10. That's what you call indolent. So that's the 3 types. So what is the treatment for mantle cell lymphoma? Selected stage 1 or 2 non-bulky, you can give them radiation. Stage 2 non-bulky, observe less aggressive in induction therapy. You can use less aggressive induction therapy. So stage 2, this is the stage 2A, bulky, and stage 3 and 4. If it is classical TP53 wild type, stage 2 bulky, or stage 3 and 4, aggressive induction therapy, if suitable, and we'll see what we mean by the less aggressive and aggressive. Classical TP53 mutated, that's bad disease. Those are the options, which is a BTK inhibitor, Prokenza, which is zanubrutinib or Venclexta. Indolent, may observe. Here are the regimens: aggressive induction therapy. This is here in this box, and this is the less aggressive. For relapsed mantle cell lymphoma, you could use the BTK inhibitors. Here are those: calquence, prokenza, ibrutinib, lenalidomide with rituximab. These are the regimen for refractory disease, right here. And the very last, you could use cytotoxic chemotherapy if these new or novel drugs are not available for you for your patient. Then you could use chemotherapy, atezolizumab, rituximab. But really, the best option is to use BTK inhibitors, oral, less toxic, and effective. Now we move to marginal zone lymphoma. Types: nodal marginal zone lymphoma, splenic marginal zone lymphoma, extranodal marginal zone lymphoma, which you call MALT, or mucosa-associated lymphoid tissue. Either it could be gastric, it could be non-gastric or non-cutaneous, which is either it could be in the bowel, small bowel, large bowel. Of course, the stomach is different. Breast, lung, dural, ocular, adnexa, ovary, all of these. Prostate, salivary glands, head and neck, thyroid, or it could be cutaneous. So these are the types of marginal zone lymphoma. Is a low-grade lymphoma. Histologic transformation could happen. So marginal zone lymphoma arises from post-germinal center marginal zone of the B cells. This is the flow cytometry. So it is characterized by being cyclin D1 negative, different from the mantle cell lymphoma. So H. pylori positive, if it's gastric, it could be H. pylori positive, and that is, you need to confirm that with the PCR or FISH for the translocation 1118. By the way, this translocation 1118 positive H. pylori positive gastric marginal zone lymphoma less likely to benefit from antibiotics, because as we see later, we treat gastric marginal zone lymphoma H. pylori positive with antibiotics. All the time we need to check for MYD88 mutation to differentiate Waldenstrom from marginal zone lymphoma, especially if there is plasmacytic differentiation present. And to differentiate between marginal zone lymphoma and Waldenstrom, you do genetic testing for CXCR4, which is characteristic for Waldenstrom rather than marginal zone. This is a chromosomal translocation associated with the extranodal marginal zone lymphoma. Marginal zone lymphoma association, autoimmune disorders, H. pylori, gastric lymphoma, chlamydia, ocular extranodal, and Campylobacter for small bowels, Prolia for cutaneous, Acromacobacter for pulmonary. The nodal marginal zone lymphoma we treat as low-grade lymphoma and follicular lymphoma. So we follow the same path. Stage 1, we give RT. Stage 2 and 4, chemo RT, marginal zone lymphoma, H. pylori. Basically, we treat if it's H. pylori negative, radiation. If it encompasses in one field, if it's H. pylori positive, we treat with H. pylori regimen and repeat EGD. Basically, the key here is to eradicate the H. pylori if positive with antibodies, except the one that with the translocation 1118, they don't respond to the antibodies. Basically, otherwise you give H. pylori regimen to eradicate the bacteria, and you may need more than 2 regimens before you can say it is not effective. If advanced, still eradicate, you may observe. And very last, you use rituximab for symptomatic patient with or without chemotherapy. Non-gastric lymphoma, non-gastric marginal zone lymphoma. If it's limited, stage 1 or 2, observe of radiation. If advanced, treat similar to nodal marginal zone lymphoma. Extranodal marginal zone lymphoma of any site and stage, plus large cell lymphoma, treat as diffuse large B-cell lymphoma. cutaneous, as we said, associated with prolia. If it's solitary radiation, splenic marginal zone lymphoma, characterized by splenomegaly and villous lymphocytosis, autoimmune manifestation in 20% of the cases. This is the flow cytometry for that. Splenic marginal lymphoma treatment. If asymptomatic, observe or we treat the autoimmune complications. If hepatitis C positive, antiviral for hepatitis C. Splenectomy, they consider that in certain cases. This is the regimen, first line for marginal zone lymphoma, rituximab single agent, or rituximab with chemotherapy, R-CHOP, bendamustine, CVP, Cytoxan. Second line and beyond are right here. Basically, we use anti-CD20s with chemotherapy, or may use BTK inhibitors right here. These are all oral third line CAR-T or allogeneic transplant. Complications, so marginal zone lymphoma may present with complications, especially we're talking here about the splenic marginal zone lymphoma. What are the complications? It could be an autoimmune hemolytic anemia, or ITP, immune thrombocytopenia, cold agglutinin disease, antiphospholipid, or acquired von Willebrand disease. So these are all could be complication of, so they may present with complications rather than lymphadenopathy or splenomegaly. It could be autoimmune complications. This is for the autoimmune hemolytic anemia. Basically, this is an IgG, autoimmune hemolytic anemia. We usually warm antibodies. And here the test, which is a direct Coombs, which is direct antiglobulin test. Or this is an indirect. So it could be a primary warm autoimmune hemolytic anemia, and this is secondary. This is just a little bit about more hematology. Treatment is steroid, rituximab, Cytoxan could be used. Remember to give them folic acid. And remember, all autoimmune hemolytic anemia, they're at risk for VTE, venous thromboembolism, almost 30% of patients. This is just a treatment for ITP, classic, like treat like any ITP with the steroid, IVIG, and here I'll just leave this. You can review it later. This is just the choices to treat ITP, including the TPO receptor agonist. Cold agglutinin. If I have to mention two things for cold agglutinin disease, which is hemolytic anemia on exposure to cold, it's an IgM disease, DAT positive with anti-3, negative with IgG. So these are the treatment for severe cases. We use plasmapheresis, and now there's a new drug for that is Enjaymo. This is for the cold agglutinin antibodies. I just have to mention that is you need to check the titer for the cold agglutinin titers. Now we move to lymphoplastic lymphoma, LPL, also called Waldenström macroglobulinemia. Basically, if it is in the lymph node, we call it lymphoplastic lymphoma. If it is only IgM high, no lymphadenopathy, we call it Waldenström macroglobulinemia. It is the same disease. It is a lymphoma of bone marrow. If the bone marrow involved by more than 10%, that's commonly involved the spleen or lymph nodes. It's an IgM monoclonal gammopathy. May present with hyperviscosity syndrome, and here are the features of the hyperviscosity syndrome. It is associated with MYD88 and CXCR4 gene mutations, which is characteristic for this disease. I think we mentioned this or the other marginal zone lymphoma with the other low-grade lymphoma to differentiate between these two diseases by doing these gene mutations. So the treatment for Waldenström disease, basically, it's symptomatic. We treat them with BR, bendamustine, rituximab. Here are some options for the Waldenström. Alternatives. if a patient presents with hyperviscosity syndrome, the treatment of choice is plasmapheresis to remove the IgM. AIDS-related lymphoma, this is just a type of AIDS-related lymphomas. Go quickly over those. Antiretroviral therapy plus chemotherapy give a higher rate, so you treat the AIDS and the lymphoma at the same time. Avoid zidovudine, chemo regimens. Remember just to hold the rituximab if CD4 count less than 50, because rituximab also wipe out the B cells, so we don't want to lower the CD4 further. Remember to prophylaxis for PJP, herpes, candida prophylaxis, enteric organism prophylaxis. Now we move to a different type of lymphoma, which is the T-cell lymphoma. We cover almost, not all of them. Still, there's some B-cell lymphoma we did not cover, but those are the most common. So we cover the B-cell. Now we move into the T-cell. Remember, the T-cell has a lower CD, like CD3, 4, 5, but it has some of the higher, which is the CD30, and it has an implication on treatment, and also ALK, it could be ALK positive, ALK negative. So those are the two that we need to know when we diagnose T-cell lymphoma, the CD30, is it positive or negative? ALK positive or negative? That is affect our decision for treatment. These are the subtypes of peripheral T-cell lymphoma, NOS, anaplastic large cell lymphoma, and then there are others. This is all subtypes of T-cell lymphoma. It is not very common, less than 50% of non-Hodgkin lymphoma. This is the immunophenotype of the T-cell lymphoma. This cytogenetics treatment. Remember, we said the CD30. If CD30 positive, that means more than 10% by immunohistochemistry. The treatment is brentuximab. Brentuximab plus CHP, Cytoxan, doxorubicin, and prednisone. If CD30 negative means less than 10% of the cells positive by IHC, we call it CD30 negative. It depends on the age. If they're less than 60-year-old, we treat them with this chemotherapy, which is CHOP plus etoposide, or EBOC, or hyper-CVAD. If they're elder, more than 60-year-old, or medically unfit, we treat them with CHOP. Consolidation, you need to consolidate with radiation or stem cell transplant. Anaplastic large cell lymphoma. If it is primary, remember we said the ALK. If it's ALK, we call it ALKoma. If it's ALK positive, ALK positive, and CD30 positive, we treat them aggressive. It's an aggressive form of lymphoma, but better prognosis. If it's ALK negative, the risk factor for that is HIV, CD30 positive, and this other type of ALK lymphoma. This is a treatment for the primary from the anaplastic large cell lymphoma. If you CD30 positive, then we treat them with CHP, with the brentuximab. Basically, instead of R, we use brentuximab, which is anti-CD30, with the Cytoxan, doxorubicin, prednisone for 6 cycles. If they achieve CR, we observe. If they're young, we consolidate with a stem cell transplant. If the CD30 negative, then of course brentuximab is not a choice. If they're medically unfit, we use CHOP. Otherwise, we use this aggressive regimen, which is CHP with etoposide. For stage 1 or 2, not able to tolerate chemotherapy, you can give short chemotherapy followed by RT. If relapsed, these are the options. Adult T-cell leukemic lymphoma, ATL, characterized by association with HTLV1. It has 4 types: acute lymphoma type, chronic, and smoldering. Chemotherapy is very complicated regimens. Cutaneous T-cell lymphoma, mycosis fungoides, and Caesar lymphoma. For the mycosis fungoides, we treat direct the skin, either topical steroid or ultraviolet light. If advanced cases, here are the options, all the way from radiating the affected area, all the way to systemic therapy. Sézary syndromes, it's an aggressive leukemic variant of cutaneous T-cell lymphoma, basically circulating malignant cells in the peripheral blood, Sézary, very characteristic under the microscope. Treatment, systemic therapy, skin-directed therapy. Okay, we are done. Here are the take-home messages. Message number one, remember, lymphoma is a heterogeneous group of malignancies. There is no common clinical presentation. It differs based on histologic subtypes, as we have seen, sites of disease, diagnosis. You need adequate tissue for proper diagnosis and classification. Remember, no FNA, fresh tissue is needed, unfixed. Don't send specimen on formalin. Flow cytometry, molecular fish play crucial roles. Message number two, not all lymphomas require immediate treatment. Some could be life-threatening if not treated, and if not diagnosed and treated urgently and aggressively, like Burkitt lymphoma. Immunotherapy with anti-CD20 rituximab is used almost in all B-cell lymphomas regimens. So make sure you test for hepatitis B virus, and when you check, you need to test, which is hepatitis B surface antigen and core antibody. If they're positive, give them treatment before you start rituximab. Otherwise, the virus may flare up. Be aware of tumor lysis syndrome, spontaneous in case of Burkitt lymphoma, and therapy-related on other lymphoma depends on the tumor burden. Message three, diffuse large B-cell lymphoma, two types, the germ central B-cell lymphoma, relatively good prognosis with R-CHOP, and now we have another option, which is polar R-CHOP, as we have seen from that study. Non-germinal germ cell B-cell lymphoma or activated B-cell ABC lymphoma, high relapse rate, less favorable prognosis with R-CHOP. If we use R-CHOP, add to it something, as we said before, like Revlimid, for example, lenalidomide. All diffuse large B-cell lymphoma should be checked for c-MYC, BCL2, and BCL6. Why? To rule out double hit lymphoma, because this is a different subtype, treated differently, has a high relapse rate for prognosis with R-CHOP. And this is the end. Thank you much.